It's my privilege to be here with you today. Tom Judd here from Atlanta, Georgia, USA. Hey, we had the Olympics here in 1996. And to represent both the IFMBE, International Federation of Medical and Biological Engineering, Clinical Engineering Division, CED as we like to, but to present to the LIU, extended family there, and representing the Global Clinical Engineering Alliance and our work around Global CE Day, Clinical Engineering Days. And speaking on the topic of clinical engineering making a difference globally in partnership with WHO, particularly the last couple of years. And I do have the privilege of leading CED and a part of this new, started last October, Global Clinical Engineering Alliance, GCEA. 25 years with Kaiser Permanente, and get to serve on some editorial boards and have worked with WHO for over 30 years. So what is clinical engineering? And I know, you've had great speakers, Dr. Sandham and Frank Painter and others, and speak to this issue. So I'll go quickly because, I want to get to 3 stories. I want to tell you 3 stories in our short amount of time today. Just before I jump into this, I know you can read the screen about clinical engineering from a WHO, World Health Organization perspective, which I think is a great way to reference our global profession. But I did send you out 3 background documents, and they were a little bit funny. They came from some work in China a couple years ago, and if you look at the date, it's an interesting date, late November 2019. And I was in Suzhou with Dr. Yadin David and others, China, which is right down the road from Wuhan, where perhaps the virus started. But fortunately, I've stayed healthy, and unfortunately, so many of our friends around the world have suffered. And so that's a hard thing, and our profession's trying to make a difference in the midst of that suffering. So I hope that's part of what inspires you. But China has a clinical engineering certification program that Dr. David has contributed to for 20 years, myself for about 5 years. Our friend and colleague, Dr. Jim Weir, has contributed to for many years. And so really one of the models that's a good one, if not a great one, for clinical engineering certification, typically 3 or more years of experience in a hospital with the right education behind you, and then you take an oral and a written test. A great model has been one that was developed in the US, and Frank Painter and I were very involved in that 30 years ago. My point is, some of the key issues defined in that certification process are health technology management, aspects of clinical engineering practice, service delivery management, SDM, of clinical engineering practice, and also, the newer but still been out there a while, ICT, communications technology, information and communications technology, which really morphs into what we call today digital health. So HTM, maintaining things, SDM, and ICT are really the background. And so in those documents, I showed some exam questions and some major principles and some case studies, and I'll come back to that after a while. So those are good reading and pretty foundational. But WHO defined health technology, you see here, kind of a comprehensive approach. And WHO on their website noted in 2018 that, what's a clinical engineer? Well, there need to be trained and qualified medical engineering professionals to do the full gamut of life cycle management: design, evaluate, regulate, maintain, and manage, and train. And in that WHO site, it says this could be called biomedical engineers, could be called clinical engineers, health technology managers, depending on local terminology. But let me fix on the term today, clinical engineers. And actually, WHO back in 2007 did a global resolution. WHO has, as you may know, 194 member states, that are typically the low middle income countries around the world, and they really try to meet the world's needs, and particularly for the more vulnerable populations. And they started talking about health technologies formally back in 2007, and that's driven the more recent versions of our profession in the last 20 years. So let me cut through sort of all that words to what are the unique competencies of clinical engineers. And, I show the picture of MENA and, a couple shots here, Lebanon in the middle of it. And I know you guys are even, I was hearing from the professor here that you're even in Mauritania. That's cool over there in the, Western Northern Africa. So anyway, you have an opportunity to make a difference in your region and beyond, in places that don't always get great clinical engineering, although, there is history in your region, and I'm not saying otherwise. But what are the unique competencies? And actually, IFMBE CED, and I'll show this on later slides, has brought people together from around the world to try to say, how do we get the recognition we deserve as clinical engineers for the work we've done the last 50 years? And we need to be able to communicate what our unique competencies are. And they are, as you see here, these 10 are certainly a great starter set. Maybe there's more. But assessing and managing, HTM, cost effectiveness, containing costs in the hospital systems and in the hospitals where you serve, increasing return on investment. Certainly we're way about quality and safety, improving health technology related patient and staff quality and safety. We partner with clinicians. That's one of our unique things, that we know a lot, the doctors and nurses know, and we're there on the front lines working with them and helping them. We're all about innovation. I think in our DNA as clinical engineers, we're always thinking about how to improve whatever it is we're doing. Digital health, I mean, that's WHO term for all that stuff. When people ask me, what do you do? And I hold up my smartphone. Maybe you can see it, maybe not right now. But, our smartphones today are driving a lot of digital medicine tools. Certainly, we're increasingly involved in global regulation and national regulation around health technology, policy and legislation, and make sure we help develop the right policy and legislation around these things, like how's your country going to use telehealth? Well, that's huge in 2020 and 2021 in the context of COVID. We want to partner with other health leaders in addition to the clinicians, and be able to have great communication with healthcare decision makers, and to partner with the other people out there fighting the battles with us every day, the allied health, partnering with those folks. How do we do our work? By the way, these 10 competencies, we had hour-and-a-half-long webinars last year, CED did, and you can find them at that website link that and what we did is we had 3 or 4 people with best practices in each of those 10 areas from around the world. I really try to balance, WHO sees the world through 6 regions, the Americas, that includes North and South America, through the lens of Europe, through the lens of Eastern Mediterranean Regional Office, IMRO, which is where you reside, Southeast Asia, Western Pacific, and Africa. So through those 6 regions, I try to get best practice speakers from all of those areas. And so you'll find those webinars, I think, incredibly rich and helpful to go deeper than I'm going to be able to go today. Let's see. But as you deliver and as you grow in the profession and you go learn what the best practices are and execute on those best practices, you're going to encounter opposition. You're going to encounter challenges. What are the leadership principles? And we talked about these in these programs last year. How did we overcome barriers? What do we need to know about leadership that will help you grow in your ability to do more and more as a clinical engineer? And these 12 items that you can look at later, being a part of an innovation culture and understanding how technology is clinically used, and the fact that we do things based on evidence, and that we have to be able to adapt in our decision maker and so on. All of these are important. But so that was just the introduction. So I've been, I was at a leading health system in the US for 25 years and over 40 years in healthcare, and I've been working with WHO a long time, as you noted, and I get to lead this CED and a part of this new alliance. CED, IFMBE Clinical Engineering Division, now has over 310 health technology leaders from 120 countries on our board and collaborator group. And what does that mean? That means we meet monthly. We take input from folks. We've averaged 50, 60, 70 people online on Zoom calls, hour-and-a-half Zoom calls in recent months. What do we focus on? Historical life cycle management of medical devices, but also global digital health. And we do that very closely aligned with Adriana Velazquez and others at WHO, both in Geneva and in the regional offices. And as I said before, a new alliance was born in 2020. Why did we need a new alliance? Well, we were not able to do global research and get paid for it so that we could do more good things. None of that money goes into our own personal pockets. It goes back into our organization to be able to do more things to serve people. And actually, literally the week that the alliance was born, we got a contract with WHO with a much larger group of people, mostly individuals, to do an evaluation of innovation products submitted to WHO last year in the context of COVID. And so the alliance immediately started to do things that its charter allowed that we couldn't do as CED. So we partnered together with the alliance very closely. So we are making a difference globally through some things I'm going to show you now, our summits and so forth, and our webinars. But I will end in my last 10 minutes, I hope, in a few minutes here with some stories. So yeah, my background, you know, I've gotten to do CEHTM, quality and safety, digital health. I invented with colleagues the advanced clinical engineering workshops, and there's now been more than 50 of those, and then working with CED, who's grown substantially around the world. So CEHTM and digital health has been our sort of mantra. And you can see we had this is right after our summit meeting that we had in Rome, which was our last big Congress, and we have one coming up. You'll see here in a moment in Orlando this September. We had people, we had 1,000 people from 70 countries at our last Congress. All right, here, what do I got? So our worldwide footprint, really since Rome, we had about 100 collaborators, and since then we've grown to over 300 from 120 countries, as you heard. One of our key tools that we use is the Global Clinical Engineering Journal. You know, when I was a young clinical engineer, I was looking to be a part of journals like this, and now there's a wonderful journal out there that you can be a part of. So what do we do with our 12-person board and our 300-person collaborator team? Well, we do 12 different projects, and you can read about them here, but hopefully it's all the things that I've sort of alluded to before. Here's the Congress coming up. This is our 4th one. We started in China in 2015, in Brazil 2017, in Rome in 2019, and coming to Orlando and Disney World here in this September. Every year since 2015, we've had something called Global CE Day, and it's really sort of morphing into Global CE Week. They're in late October every year, and you can see last year we had 22 hours of programming that our Chinese friends hosted for us, with 60 interviews from colleagues from 50 countries. So pretty cool deal. These summits that we do at all of our congresses, you can see have had an increasing footprint of 15 countries in 2015, 30 in 2017, 48, even though 70 countries attended the Congress, and we hope to have maybe 120 countries either on-site or virtually involved this September. One thing we've done is publish success stories of clinical engineering and health technology successes around the world so that we could take these to the ministers of health of the various countries and say, here's why you should partner with us and we should partner with you. So this has been published in the Global Clinical Engineering Journal. You can look that up. What are we working on now? Professional identification, recognition, engagement internal to the profession and outside. By the way, we have a monthly newsletter that we send out to about 33,000 people around the world in 210 countries. Leadership training, we're trying to help credentialing, which includes certification around the world, policy legislation, and publications, as you saw. We've had a lot of growth. I won't go over everything here, but our work with WHO last year around COVID brought us in touch with representatives from 145 countries. And after Rome, we were working with 82 countries, and today it's more like not 139, but really 170. And what did we do last year with WHO? Well, we started a knowledge network that included monthly webinars with our monthly meetings where Adriana came and she recruited various ones of us to be involved in WHO's work. We had this newsletter I mentioned, and actually we've got something called, we've got a WhatsApp group that many have joined, and we don't encourage everybody in the world to join our WhatsApp group. even though it's got 160 people from 60 countries. We encourage, people like Bassam Tashuri and Riyad Farah from Lebanon to be involved, and then to start a WhatsApp group in Lebanon and beyond, so that you guys can communicate maybe in your own language, or you can communicate easily. And then we've had for 15 months now a weekday daily COVID newsletter where we vet, where we look at all the flood of information coming about COVID and clinical engineering and health technology and healthcare, and we send this out daily to 11,000 plus subscribers in around the world. So you might want to be involved with that. Our work in the bottom right there of this slide, what did we do with WHO last year? Well, we tried to address key COVID-related equipment issues from a systems viewpoint. And you see clinical requirements, supply of equipment, resource accessories, manuals, training, coordination, decontamination, and safety management. So how am I doing on time here? Got about 12 minutes maybe. But, we're not done with all this, and we need your help, in getting it in the right languages, helping us expand how we look at things, so together we can make it better. Here's a taste of some of the webinars we did. In the middle, CPAP, BiPAP, and oxygen, and actually PPE is seen by WHO as a medical device, and oxygen systems, not only oxygen concentrators, which is a device, but oxygen systems, how you pipe it in there. Those are the kinds of things we did. In fact, we've got a webinar coming up on May 19th and 20th, in a couple of weeks, with a bunch of global friends and clinical engineers on addressing the oxygen challenges. But we also had these competency webinars you see on the left, and we had international webinars, as you see on the right, in this case with our on digital health with our friends from Saudi Arabia. And here's a little bit of drama. We had a social media explosion last year, and the net of it is, through all these channels I've been talking about, we had over 1 million touches in our profession around the world. But what are some conclusions we can take out of all this? Is that CED is working hard on digital health, clinical engineering competencies, and COVID-related issues. Here's a slide from our digital health program last year, which is one of our competencies. And it's basically so think beyond, normal clinical engineering and medical devices in hospitals. We try to help healthcare data be cleaner so that it can be used. One of our collaborators in Pakistan, her grandmother died because health information wasn't going fast enough between the doctors. So she created a new electronic health record so that you get clean, timely healthcare data, so it could be shared among providers, so that grandmom doesn't have to die. I'm not trying to be strange here, but you can make a difference in your own communities in the different ways we can approach these issues, in this case digital health. Then a huge issue we all know is about cybersecurity issues, and we talked about that in our webinar last year. And this is from Axel Worth, who's German but lives in the US and works on this every day. And then this was an individual, Alex, or Mr. Ritz from Canada, but who works across Africa, trying to help create digital health infrastructure, so that what happens in the community and the village and the district, and working with the Ministry of Health and the NGOs and all that, can all be combined, getting all that digital information combined to make healthcare go easier. Earlier this year, we did a webinar, global webinar on COVID vaccines and what clinical engineers can do in that. And then we did health technology management innovation in the time of COVID around some key issues I've already described. So, okay, Tom, you got about 10 minutes. What are your stories about clinical engineering? How might I encourage and inspire? Well, I was at a place called Baptist Medical Center as my first, actually, I was a naval officer and a pilot, and then left that at age 29. And during the last years of that, I was a professor of systems engineering back at the Naval Academy, where I did undergraduate. And at night, I went to Johns Hopkins and studied biomedical engineering, and worked at Hopkins Hospital there in Baltimore for a year, 79 to 80. But then I went to my first hospital to start a clinical engineering program. So 1980 to 84, I had a plan, like you all do when you go to a new place and you have a new plan, but you know something about your profession. And The plan was I wanted to do, the full range of health technology management activities, that are described in that background document at that hospital. The first year with general biomedical equipment, the second year with imaging equipment, and that's a tall order. This is complex, can be complex stuff. I mean, including it back in the day that MRI wasn't even out there then, but CT scanners were. The third year, clinical lab equipment, once again, a whole different kind of set of technologies. In the fourth year, personal computers were just coming out, and there was a lot of computer-based medical devices. So that 4-year plan, where I do the full range of health technology management activities, was the goal back in the day. And we did that successfully. And actually in '84, we started a independent service group to service other hospitals. And I'm happy to say that that group we started, that small NGO or that small for-profit arm, is still working today. We called it CE Tech, Clinical Engineering Technology. CE Tech, 37 years later, is still going on. My favorite way of talking about that is after I left, they really got good. So anyway, Baptist Medical Center, sort of straightforward, simple life cycle management, but hard to do stuff. And those kinds of things are still being done by clinical engineers around the world today. I had the privilege, as you heard, for working for Kaiser Permanente from 2006 to 2016, about 11 years there. And then we took those same areas, general biomedical, OR, ICU, emergency room, and all that, and imaging and clinical lab. And now we added digital health. And the big story there was, one of my favorite areas was what they call integrated operating rooms. And where now the electronic health record says Mrs. Jones is about to get a surgery. And so the electronic record turns on the system in the OR, turns on the equipment. And then as you make images of Mrs. Jones during surgery, they're all captured. Digital images are captured, put back in the electronic health record. And then the doctor at the end of the procedure can go look at those images and select, maybe I saw a tumor here, and draw on that and annotate that digitally and so forth. And then all that stuff is kept, but then how does all the equipment in the room interact during the surgery? That would be a more complex example. And bringing health technology management to a health system that has maybe different manufacturers of all the components in that integrated operating room. We called them digital operating rooms, where you help, if something breaks at one hospital, how can you help another hospital, or another hospital can help that hospital get fixed, or maybe you have to transfer equipment. That becomes a more complex health technology management with digital health. And then, I've been, as you heard, with Clinical Engineering Division for 6 years now. Well, digital health with clinical engineering applied to it is changing the way healthcare is done. I gave an example back in the slides of, and maybe I have this in my slides here, so we'll see. This is about clinical engineers involved in digital health and medical device integration of device information into electronic health records. But this is the example I'll close with. So I was traveling, I guess, for private reasons into Xi'an, China, and ran across a pediatrician that had a practice there in Xi'an. Now, Xi'an's a city, all the cities in China are pretty big. I think it's about 10 million people in Xi'an. And this doctor had a 25-year pediatric practice that, down the street from this doctor and all these high rises where all the families live was probably 150,000 people. So what's my point? This pediatrician and his long-standing practice had they had an access problem. They had a challenge to get all the families in there and to do it wisely and to do it safely and with quality and a way to deliver care. Now, this practice had maybe 10 pediatricians working for the head pediatrician. They were doing not only traditional medical care as you and I would understand it, but also traditional Chinese medicine, which is interesting, another story. But he wanted to know how to enhance, as it says on the slide, patient access, to make sure his staff was up to speed with the best use of digital tools, and to implement tools and medical devices in a way that improve quality and safety. So access, training, and implement new tools. So in this model that we came up with, that I and another clinical engineer and a health system leader or an administrator type, is trying to combine, I'm talking about primary care here in a clinic, a big clinic, but it also combines how do they work with the hospital or the teaching hospital, the secondary and tertiary, in such a way that it's culturally relevant, it's efficient, et cetera, et cetera. And here's what we did. Long story short, a lot of words on the page here, but I'll try to tell you this in a story fashion. When a patient family walks in, and with a child, you're going to come in with your family members. Let's say they can go up to a kiosk, and maybe there's 10 kiosks and they're separated by a wall so that, the family doesn't have to look at what's happening with the family next to them. And then, so that family goes in and dials into that kiosk and gets a screen, and they see not only they can put in what they want to do today with the doctor if they haven't already communicated that, and they can look at their own medical history of the children that they're bringing in to see the doctor. So all of that's at the screen at the kiosk as they check in. And so, maybe the screen says back to them, well, I'm glad you brought in, daughter Susie today, but she needs to be able to address the concern that you come in with today. She needs a lab test. And so there's a lab in this facility, 3 or 4 story building. So they may catch and go get the lab first and then go see the doctor. So, all those sorts of things. So that's registration and triage, unless they come in very sick, and then they may treat it like an urgent care emergency room and take them right back to see the provider right away. But then so everybody knows as much information about them, both their history and what's going on with them today, as they go back into a room to see a doctor or a nurse or both. But when they get there, the condition they're going to get treated for today, or the set of conditions, has evidence-based clinical protocols behind them, so that ahead of time, what devices do I need? What medicines do I need? What supplies do I need to be able to treat this condition this day? And so you've done all that analysis. And then, if dental care is involved or traditional Chinese medicine, there's another space for that. So, so what we ended up saying to them is, clean up the outside of the building to make it look better. When you come in and you work with this kiosk, you have an electronic health record that has computerized order entry for lab, imaging, pharmacy, gives you clinical support ideas for the condition that's being treated. Even before you come in, while you're in there, and after you come, use the local tool for, it's like WhatsApp. In China, it's called WeChat, for clinical communications, appointments, and payment. When you check in, all that's communicated through your phone and your kiosk, so you got the phone and they've got the kiosk. How does all that talk to each other? If the child has like chronic disease, in this case in a child it might be asthma, what are you doing to treat that asthma when the child is not in the doctor's office and at home? So that, they maybe you can get medicines without coming to see the doctor through those kind of digital tools. Social media can help you deal with advertising, scheduling, providing follow-up care, doing preventive care, et cetera, and maybe sending people to a YouTube to look at how to deal with something. The medical devices are all used where, like I said, where appropriate for evidence-based protocols, and then so on. So why do I tell you all this? Because this is when I started, clinical engineering was about health technology management and maintaining medical devices. Today, it's about all of these things. And so let me stop there, and Mohammed, and take any questions.